Okay, everyone, we are going to get started now. It is a little bit after noon and we have a very packed agenda, so let's kick it off. I would like to welcome everyone and thank you for tuning in virtually. My name is Rachel Rennick and I am part of the Community Outreach and Education Program at Perlmutter Cancer Center, and we have a great program for you today. This event is presented by the New York City Regional Cancer Collaborative, which is a partnership between 8 NCI-designated cancer centers. And I would like to thank all of them for making this happen today. We work together on different cancer-related initiatives throughout the year. So thank you to everyone for participating. For everyone joining us today, we are going to have time for questions at the end. So please take note of the Q&A box on your screen. Type in any questions you have, and we will take as many questions as we have time for at the end of the program. And with that being said, I'm going to turn the program over to our first speaker today, urologist from Columbia, Dr. Joseph Alougal, and he is going to give you an overview of prostate cancer. So Dr. Alougal, take it away. And I'm going to stop sharing my screen.
Rachel, thank you so much. And hopefully everyone can see my slides. It's really a pleasure to be here. Again, my name is Joe Alougal. I'm a urologist on faculty at Columbia. And I'll be talking to you a little bit about the basics of the prostate cancer, and as well some of the related questions regarding how do we diagnose prostate cancer, and that'll lead us into a real quick discussion of PSA testing. Certainly I'm happy to field any questions as we go, but it sounds like we've got some time at the end for questions, and so we'll make sure to try and get all those answered. I've got no disclosures that are relevant to this particular talk. So prostate cancer is a common condition, and we all know somebody who's been affected by it. Certainly that has to do with the fact that it's the most common solid cancer that occurs in a man. Thinking broadly, we have options to treat it. And again, this is something that I know people on the call are going to have familiarity with, that includes surgical treatments or radiation. And we have some other treatments that I might characterize as new, things we can do to actually treat the cancer itself within the prostate. We call those focal treatments, or our very deliberate efforts to observe men who we think have low risk prostate cancer. We call that active surveillance. But big picture, I suspect the stories you would have heard from men in the community who you know, friends, family members, include either having been treated with surgery for this condition or with radiation. Both of those treatments can cause problems, including things like a change in the way the patient urinates. He might tell you that he leaks some urine. Problems with erections, which actually is relevant to my practice because lots of men come in to see me about those kinds of issues. And as I said before, this is a common problem. We don't exactly have a handle on how many men carry around a diagnosis or are affected by prostate cancer, but we suspect it's more than 2 million men in total in the United States today. So again, I'm talking about a common problem. Here are some things that we hear commonly expressed by men out there when you talk to them about their prostate. I hear these things from patients, and I know men will tell me that they've heard these things from, again, friends or family. No one needs to have an examination of their prostate anymore. Nobody's got to put their finger back there. Isn't a blood test for this condition good enough? No one dies from prostate cancer anyway. Why do you guys have to look into this problem? A biopsy of my prostate might cause cancer that I could have in my prostate to spread. Why do I want to undergo a biopsy? And lastly, if I get treated for prostate cancer, no matter what you guys choose to do to me, I won't be a man anymore. And so these are all things I've heard expressed in some way, shape, form, or fashion from my patients. And these are all myths. I've put this under this header on this slide for a reason. I want us to try and address these things and make sure that you guys understand that these statements aren't true. And hopefully we'll have a better understanding at the end of this in terms of what we should be doing, correct practice with regard to prostate screening for prostate cancer and treating prostate cancer. So first question, simplest question, what is the prostate? Some of this on here, you know, is appropriate to a medical student or a urologist in training, but you know, a lot of it I think people can be made to understand. It's a gland, it belongs in the reproductive tract where it plays a role in reproduction, and it's found in almost all mammals. its only job, other than to cause us trouble as men, it's to make most of the fluid that goes into the ejaculate or into semen, and then to actually play a role in that event to cause or enable ejaculation. The prostate also in men, separate from cancer, can cause all kinds of other issues. As we age, the prostate grows. That can cause urinary issues because of the prostate's relationship to the bladder. And we'll talk about that a little bit more in a second. It can also be a site of chronic pain or inflammation. It can be a site that becomes infected. And so those are complaints that very often will put the patient in front of a urologist like ourselves, the people on the panel today. And we'll talk a little bit more about those conditions in a moment. Like I said, the anatomy of the prostate has something to do with some of the myths that we were talking about and some of what goes on when you see a urologist. This is kind of a, if you can imagine a cross section of a man viewed from the side. This large structure here is the bladder. It holds urine, and when the patient is ready to urinate, it contracts and helps to expel urine. The prostate and the bladder are next door neighbors. And so the prostate is actually encircling the tube that the bladder uses to empty itself. And so as the prostate gets bigger, as a man gets older, it can make it harder on him for him to urinate in a controlled fashion. Relatedly, the prostate lives right next door to the rectum. And so this is why when one of us says we want to examine your prostate, we do have to put our finger back there in order to feel the surface of the prostate and to make an assessment of its size. Relatedly, if you're going to biopsy the prostate looking for cancer, this happens to be one of the best approaches to get to the prostate. And we do have biopsies now that enable us to, again, view the prostate either with ultrasound, MRI, or both, but maybe still including this probe that goes into the rectum. But now we can pass a needle to take a biopsy sample of the prostate through the tissue at the bottom of the pelvis behind the scrotum, what we call the perineum. But for many years, if we were going to biopsy the prostate, the only approach we had to do that was also through the rectum. And so these are the kinds of things that result in men being out in the community and saying to their friends, oh man, I had to go see the urologist, he had to put his finger back there, or I had to have a biopsy of my prostate, and that wasn't comfortable or any fun either. And so we recognize that these are all things we'd love to be able to improve upon. But as it currently stands, these are the only ways we have to assess the prostate for size, to diagnose prostate cancer, and we continue to work within the confines of what we have available to us. Important, I want to address one of those myths already. This is, like I said, the only way we've had to diagnose prostate cancer for years and years now, decades. And so anybody you know who's been cured of prostate cancer, he has had a needle biopsy of his prostate, and it did not result in the spread of his cancer as an automatic event. Okay, so I use that to remind people, hey, a biopsy of your prostate is safe in terms of there not being a chance that we're going to cause a cancer that might be in there to spread. This is an image of a man's prostate. And so again, a cross-sectional image, but now we're looking not a side view, but an up or down view. And this is in the pelvis. This is using a very, very powerful MRI with a powerful magnet. And right in the middle here is, again, this prostate. Up here is the patient's pubic bone. And again, here, back here is the rectum. And again, why we would put our finger back there in order to feel the prostate. So some of the other conditions aside from prostate cancer that again would put you in front of a doctor like myself. Enlargement of the prostate. Again, as men get older, without exception, their prostate will get bigger. No other organ in your body is dumb enough to keep growing like this once you get done with puberty and your growth spurts. But your prostate, which may at the time be the size of a walnut or smaller, might end up by the end of your life being as big as, say, an orange or a grapefruit. And obviously those kinds of size changes can create problems. That's a common reason to see a urologist. 500,000 guys every year in the US come in to see a urologist saying, I don't pee the way I used to, and I think it's because my prostate might be big. As I alluded to before, there's people who will tell you, I have pain down there, doctor. And a urologist told me before it has to do with some inflammation that has developed in my prostate. A common condition, difficult to treat, again, requires a urologist. And then lastly, of course, what we're here to talk about today, prostate cancer. We believe that every year in the US, 1 million men approximately will wake up having a prostate cancer in their prostate that they didn't have at the beginning of the year. Not all those men get diagnosed. It is about 200,000 men every year in the United States who are given a new diagnosis of prostate cancer after a biopsy. That number changes a lot. It's been as high as 230, 240,000, as low as 190,000 in the past few years. And the other panelists will talk about some of the reasons why that variation might occur. Almost all these men, when they're in front of a urologist, at some point, in addition to that exam I talked about, they're also probably going to get a blood test check called a PSA. And that we're going to talk about that some more also. That's a test we use to screen for prostate cancer. But unfortunately, all of these conditions can cause a PSA to come back and to give you an abnormal result. So that can create some confusion. We can talk about that for a moment now too. What is PSA and why is it confusing to us? So the prostate, again, has this function in terms of male reproduction. PSA has to do with an enzyme being made in the prostate that results in semen becoming a liquid, and that enables the sperm to swim out of it and into the female reproductive tract. We know that PSA is only made in the prostate and that only small amounts of it get out into our bloodstream. If we're going to check it as a blood test, a PSA level, we shouldn't be surprised, though, that we can get abnormal results if, again, the patient has one of these other conditions, say a prostate infection or prostatitis, or if we do something to, say, traumatize the prostate. If we've just had the patient undergo a biopsy, for example, that's not the right time to have them come back to clinic a week later and to check a PSA. We used to say for many years that a PSA blood test level greater than 4 meant that it was abnormal. We've learned over time that that's a pretty arbitrary line in the sand to draw. We have to take into account things like the patient's age, most importantly. And we recognize that just using that test alone to screen men for cancer, we are still going to miss some cancers. And unfortunately, we're also going to miss some aggressive cancers. We have tried to do lots of things over the years to better read the tea leaves in terms of whose PSA abnormality is really speaking to us about a higher likelihood of there being a cancer in his prostate, particularly an important cancer or a dangerous cancer, and things like how fast is the patient's PSA changing, or the level of what we call a free PSA for certain patients. These might be important tools that help us to understand what's going on in the patient's prostate. So I want to come back to these myths for 1 second, and then I again try and answer some questions, and as well turn it over to the next speaker. So that blood test alone is not good enough because PSA, which is what we're talking about, the blood test in question, can go up for lots of reasons. People do still need to have a physical examination of their prostate. No one dies from prostate cancer anyway. That's not true, unfortunately. It's still about 20,000 men every year in the United States who are going to die of prostate cancer. And I'll leave it to my colleagues to talk more about what the implications of that are, especially when you talk about 200,000 men a year being diagnosed with the disease. I talked about the idea that a prostate biopsy will not cause a prostate cancer to spread. And lastly, and it's an appropriate conversation for a different lecture that I've given this organization before, if I get treated for prostate cancer, I won't be a man anymore. If you get treated for prostate cancer, you develop one of the problems I talked about, urinary issues or erection issues. Those things can be treated by us, by doctors like us, and patients are very happy with those treatments. But we do have to help you through those problems if you were to develop those. Okay, I'd like to open the floor to any questions.
Thank you, Dr. Alougal. That was great. That was so informative. I know the participants are definitely going to have some questions for you, which we will take at the end. So moving right along, I would like to introduce our next speaker, Andrea Reyes, who is a health educator at Columbia, and she is going to talk to us today about prostate cancer health workshops. So Andrea, take it away.
Hi, thank you, Rachel. I'm going to share my screen. In the meantime, I'd let you know I am the health educator at Columbia Cancer Center, and I wanted to let you know that we have a suite of community workshops that are free and for any organization in the community that is interested in having workshops for their audiences. We do have a prostate workshop in English and Spanish. They are very easy to understand PowerPoint presentations that are about 30 minutes long, and then I take questions. And we also have, and I have it just pulled up here, we've got everything from nutrition to breast cancer, lung, HPV, skin, prostate, and more. So just wanted to let you know that if anyone is interested, you can get in touch with me. I will put my email, I guess, into the chat. You can also write it down right now. It's ar281@columbia.edu. Email me, and if you have an organization or if you would like to bring this out into your communities, let me know. I'll be happy to have a conversation about that. Thank you all very much. And next speaker.
Thank you, Andrea, and thank you for all your great work. It sounds like wonderful, informative workshops. So please contact Andrea if you're interested. All right, moving along, I would like to introduce Zachy Smith, who is going to share his story today. And Zachy, thank you for being here and sharing with the audience.
Thank you so much for having me. Really appreciate being here. So to get right into it, I was diagnosed with prostate cancer 2 months after my father passed from colon cancer. I actually literally just went into the hospital because, to get tested because my father had just passed. Now, mind you, my dad had no kind of conversation with me about male parts. So going into the doctor's office, I had no knowledge of where the hell my prostate was, what its function was, what it looked like, nothing. Had no knowledge of it. I went in to get a colonoscopy, and one of my clients in the barbershop said, while you're there, make sure you get a prostate exam as well too, because he was an elderly man and he had prostate cancer, right? And so I said, well, while I'm there, I asked for a prostate exam. The doctor literally told me that I was too young for a prostate exam. I said, what do you mean I'm too young for a prostate exam? He said, yeah, you're too young. I was 42 years old. And so I said, my father just passed from cancer, from colon cancer. He asked, well, how old was he? And that would have determined whether I would have received the test or not. So I literally had to lie and say that my father was much younger, dying from cancer, in order for them to give me a prostate exam. Gave me a prostate exam. My PSA was high. They did a biopsy. Boom, guess what I had? Prostate cancer. So had I not had some type of knowledge or some type of information, or even think to possibly even tell a lie about the age of the death of my father, I would not have been tested for a prostate exam at all. And so after that, I went back to him. He gave me the exam. He gave me my results and say, you have prostate cancer. It was just like that. There was nothing, no emotions or whatever attached to it. So I asked what was my options. And the first thing he said was surgery. He gave me no other alternative. He said, you have to remove your prostate. That was it. Clean. I said, is there anything else? He said, no. You have to remove your prostate. And me, 42 years old, I was married at the time. And me and my wife, we had not had any children. I said, well, listen, it has to be a different way. There has to be something else. And so I went for a second opinion. He never talked about health. He never talked about nutrition. He never talked about diet. He never talked about any of those things. I went to another doctor. He looked me clean in my face and he said the same thing, remove your prostate. I would tell this to my son. I said, you have to be kidding me. I left. Again, I did not do anything about my prostate cancer for an entire year. I actually went and did some other things just in terms of my health, adjusted my diet. I lost weight because I understood that, weight and belly fat, those are things that can contribute and associated with it. I found a third and a fourth opinion until I came across Dr. Daniel Shasha from Morningside, from Mount Sinai Hospital, who really just broke it down to me and gave me all of the options possible for me to treat the cancer and what was the percentage rate around the return of it if I took these approaches. And I was able to choose an approach from an educated standpoint, right? Because someone took the time to sort of educate me around the possibilities. They didn't just look and see, hey, you got Medicaid, so the butcher shop is where you're gonna go, right? My insurance didn't determine my quality of care, at least with Dr. Shasha. And so Because of that, I took the seed. I had the seeds implemented into my prostate to remove the cancer, and me and my wife had a child as a result as well. And so, I've been, cancer-free since 2014. But the thing is that, was these myths that I had in regards to prostate cancer that, prostate cancer did not look like me. I was a 42-year-old Black male, and, prostate cancer was for old people in my mind. And so what it sent me on a mission to begin to talk to my friends and really find out, have brothers been going to check their prostate? And again, there's these beliefs that, men have that somehow, their manhood is compromised as a result of having the finger in the rectum, and is usually associated with homosexuality. And I don't know a man who has gone into the doctor's office and now are in love with men because they had a prostate cancer exam. It just doesn't make any sense. The same as women who get a pap smear, right? They're not like, hey, I'm looking forward to going to get this done every 6 months, right? So like, it's just a mentality, and it's a conversation that needs to happen. And also, when you look in the medical world, there's just a lot of disconnection with the common folk. That folks, the medical world speaks a very specific language that the layperson just is extremely intimidated by, right? And don't want to come in to some degree not knowing or feeling stupid, right? Or like, you should know this, like, you should know where your prostate is. Again, no one had a conversation with me. I was 42 years old and didn't know what my prostate function was. I didn't know where it exists. And so my mission was more so, how do I begin to talk to young men of color, right? And my mission was high school students, not just, my age, but high school students. Hey, do you know where your prostate is? Let me tell you about your prostate now. They will never, ever forget that conversation, because they, as myself as a young person, did not have a man telling me about my body parts, right? Not my mother, right? A male talking about my body parts and its functions. And so that was my mission, has been my mission, is to begin to educate young people about the function of their prostate, diet, the importance of diet and how you eat, understanding your family's history around cancer and things of that nature. And so that's pretty much my story. And working with a few because I was in the barbershop, so I had access to men all day, and just in folks' ear, doing programs in literally in the barbershop, bringing the medical world to the barbershop, making it very, very comfortable for men to have a conversation about their parts, and the fact that they are experiencing erectile dysfunction, that the fact that they're not able to finish the task all the way through as it pertains to sex. Those are very uncomfortable conversations to have, and a lot of times men are standing before a woman doctor telling them this, right? Or ashamed to talk about it because they're actually talking to a female doctor, right? And so we'll actually be in the doctor's office and won't even say anything that they're having erectile dysfunction or that they're having urinary issues. So there's just some plain language that just needs to exist to communicate this stuff to the lay person, and to really just literally meet people where they are. And I think sometimes the medical world falls short of that. But I'm excited about the projects that are coming up by actually incorporating individuals from the community, those who have been directly impacted by prostate cancer, to now begin to speak the language and speak to the people who are in most needed services. So I'll stop there if anyone has questions.
Thank you, Zachy. That was great. And it's wonderful to hear that you're doing so well. And thank you for help spreading the word and such an important message to other people. So we thank you for being here with us today. Okay, moving on, we are going to hear about shared decision-making next. So I would like to welcome urologist Daniel Makarov from NYU and David Brown, who is a lead community health worker. Thank you for being here with us today.
Thank you, Rachel, for having us. Dave, is your,
Thank you.
yeah.
I'm here. I'm here.
All right.
Thank you. We
Great,
appreciate
great. So
you.
really glad to be able to have this conversation. I think it's, I think, Dave, I think it's really poignant that we're following Mr. Smith's account of his
Thinking the
prostate
same
cancer.
thing.
Yeah. You know, I don't know what strikes me about that story is just sort of the lack of respect for him as a person and lack of education and lack of ever asking him what he wanted through that whole story. So Dave, I thought maybe I'd give a little bit of a background to the study and then you talk about your experiences in the clinic and then we sort of wrap it up together.
Okay.
Shared decision-making actually is fits in again really well with following on the heels of that discussion, because shared decision-making is an ideal way of approaching complex decisions. And PSA screening happens to be a very, very complex decision because, like Dr. Alougal was saying before, PSA is not a perfect test. If PSA could tell you yes or no, you have a prostate cancer that's going to kill you, then it would be great. It wouldn't be a complex decision. We would easily be able to know, and we would go right ahead with treatment or say we don't need to worry about it at all. But as it turns out, PSA is a very non-specific test. Like Dr. Alougal said, there's a lot of things that can cause it to go up. So there's a lot of noise before we can get through to a signal. And to give you guys an idea of how challenging a test it is, you need to screen about 1,000 men. 1,000 men need to have their blood drawn in order to save one life from prostate cancer. That's all comers. That's in a European cohort and maybe different in a cohort of Black men in the United States. But just to give you some idea of the ballpark we're talking about. And when you talk about men who actually have prostate cancer, like they have prostate cancer, certainly not everybody dies of prostate cancer, and you need to treat 12 men to save one life. So when PSA screening was going around and it was being applied, everybody was getting screened or people were getting screened indiscriminately, I should say, there was a lot of overdiagnosis and overtreatment of prostate cancer. Because even though only maybe one man whose life will be saved, all men who are treated, their lives will be affected by being treated for prostate cancer. They'll have to deal with the side effects. We can deal with those side effects. We know how to do it, but it's definitely not perfect. So shared decision making is an idealized approach for counseling, where we're talking about difficult decisions where there's no obvious right answer, and where the answer really depends on a person's values. So for PSA screening, an example that I often use is it's certainly not right for everybody. For instance, if there's somebody who is very focused on quality of life, I've heard somebody describe it in a joking way, but I'm here for a good time, not a long time kind of thing. Somebody with that mindset, PSA screening might not be the right thing for them because it's likely it has a potential to impact their quality of life. Whereas somebody maybe who's raising his grandchildren or his family is financially dependent on him or very involved in the community, someone like that may be more it may be more right for him. But shared decision making has three parts to it. The first part is the sharing of information between the doctor and the patient. So every patient, in order to make a good quality decision, needs to understand what's going on with prostate cancer. They need to know where their prostate is. They need to know what PSA is. They need to know how likely they are to have cancer, what the results are, what would happen if their test was elevated. All that knowledge has to be there in order that's the foundation of a good decision. The second part of shared decision-making is the elicitation of patient preferences. So again, if that patient is somebody who really values, basically it's a trade-off between quantity and quality of life, and you need to understand where that patient is coming from, because it doesn't matter where you as a physician are, doesn't matter what you think the patient should do or wants to do. It's critical to understand where the patient is coming from, and then to come up with the best decision for that patient in that particular setting. Again, this isn't how all medical decisions work. If you've been run over by a car and you're bleeding out, it's not the time for shared decision making. That's a clear thing, but this is where we don't quite know what's going to happen. If we don't quite know what's going to happen, then it shouldn't be the doctor who decides which way things are going. It's going to be the patient. So sharing information, eliciting values, and the third thing is arriving at a mutually agreeable decision between the patient and the physician. So it's got to make sense. And so that's where we are. Now, as you can imagine, these conversations take a long time. And people sometimes have less than 15 minutes with their primary care doctor. It's very hard to get through all of this and do it in a quality way and come up with a good decision. So what me and my colleague Joe Ravenel, who's a health disparities researcher, who's actually done a tremendous amount of work through Black barbershops looking at colon cancer screening and hypertension screening, is we wanted to figure out a way to bring shared decision-making to make it easier for physicians, and by making it easier for physicians, make it more accessible to the general population. And we decided to do this in a clinic in Brooklyn that sees largely African-American men. And the approach, because of Joe's background and Joe's research, would be to use community health workers. So a community health worker, we have one here. We have Dave Brown, would administer all of this, do most of the hard work, the time-consuming work for shared decision-making, and connect with patients possibly better than a physician can. As Mr. Smith noted, the medical establishment is sometimes not very good at talking to patients, but community workers are better at doing that, and then sort of front load all of this stuff so that when a patient comes into to speak with the doctor, that patient is able to just focus on the important conversation. So I'm going to pass it off to Dave to sort of talk about things that you've learned in clinic and your experience with doing shared decision making with actual patients considering PSA screening.
Okay, thanks, guys. Well, one of the first things I would say is that there's definitely a deep appreciation for the men that we've encountered, just meeting someone who's not a doctor, but able to kind of discuss prostate cancer screening in a kind of informal, but still, there's a sense of them being educated. We do send out a pamphlet that we got from the American Cancer Society. We send that out to our patients. And, when the guys meet us, we get to go over that pamphlet. And as we're going over that pamphlet, that's the education piece. And, there's definitely an appreciation for, just them receiving this information. Sometimes they haven't had time to go over it, but we still will go through it. And then like Dr. McElroy said, we have a process of helping these guys to come to a very personalized decision when it comes to whether or not they would like to be screened. And so the way it breaks down is there's a knowledge portion where we will kind of review what we've gone over with the patient. And then we have a values section where we talk to them about, for them personally, what would make them go with the screening? What are the things that they're concerned about that would make them kind of not want to get screened for prostate cancer right now? We also talk about what goes into the process for them when it comes to making decisions about, making this type of major decision. And then we get into like the gentleman before us mentioned, the sensitivity of having to discuss such a, talking about your prostate is, with the things that can go wrong with your body and all of that, just having to say that to a doctor who you may or may not have a good rapport with. We really get into that, and we even go as far as to, be willing to ask those questions for the patient, when we go in, to talk with the doctor. And we also, one of the most important things we do is to elicit from them the specific questions that they have for the doctor. So that's really important because, they really need to be able to say what's on their mind to a doctor and demystify the whole issue of what it really means to get screened. So I've definitely encountered the guys who maybe they're worried about the finger thing, which the gentleman mentioned, that they're a little paranoid about the finger exam, and there's definitely that we've encountered. But I would say, for the most part, what I've learned in doing this is that it's definitely a very individualized process. And I feel like these guys really deserve the right to kind of make sure they understand, the pros and cons of what they're getting into, so that they can make a decision that best suits, where they are in terms of their own value system, their own, what's going to be good for them. So that's that's kind of, to me, it's kind of what the most important thing has been. It's just giving them the chance to make an informed decision about something so important. That's kind of what I would say. Go ahead, Doc. I'm sorry.
No. I was just going to highlight that I think that's sometimes a counterintuitive thing. I think, people in medicine, they're often taught that, they need to go get healthcare. They need to go do this. I remember when we were first presenting this study to the clinic where we are, the Family Health Center, one of the nurses said, I always tell, our men to go get screened. It's super important. And I think it was sort of very counterintuitive. We're like, we know you're coming from a good place. We know you want the best for these folks, but a good decision for some men might be to get PSA screening. But for some men, a good decision, granted a knowledgeable decision, they have to understand exactly what they have to really know about the topic and know whether it's right for them. But it can be a good decision to not get PSA screening. That can be the only right decision for somebody. But they have to be counseled properly and so forth.
Definitely. I totally agree. I remember, and it's funny, even the other projects that I've been on, it's been more of a thing where you have to kind of encourage people to get this done right. Check your blood pressure, make sure there's certain definite things that you need to do. But in particular, when it comes to prostate cancer, it's just such a different beast that you can't really go at it in that way, which that's just the way it is. And we just need to make the adjustment and do whatever is going to be best for the patient, which is ultimately what that's the goal, and that's the overall goal. So
Dave, that's the end of our time, and that's the perfect thing to end on. We're trying to do the best thing for the informed patient. And thank you very much, everybody, for your attention.
Thank you.
Thank you, Dr. Makarov and David, for shedding light on such a complex and important topic, and for all the wonderful work that you do. We really appreciate it. Okay, moving along. Next on the agenda, we are going to hear from our friends at Mount Sinai. So I would like to welcome Yahara Rojas, Errol Webster, and Dr. Wagaskar, who are going to talk to us this afternoon about prostate mobile screening unit and the outreach programs they do over at Mount Sinai. So let's welcome them.
Hi, how are you guys? Thank you for having us here. I'm Yahira, and this is Errol.
Thank you.
Dr. Wagaskar is also on the line on the chat with us as well. I'm going to actually share my screen. Where do I see that? Here we go. All right, can you guys see that?
Yes, yep, looks good.
Great, great. So we're here to talk about our mobile cancer screening unit that we've been working really hard on in the past year or so. We were very lucky to get an amazing donation from Robert F. Smith to launch this unit, with definitely working together with Dr. Wara in our department here to outfit and operationalize this unit so it can work out in the community. The goal of the unit is to educate and promote a prostate cancer evaluation, prostate cancer screening within the community, and allow us to bring these services in Harlem and within the 5 boroughs. Here, I'm just showing you guys a couple of pictures of the unit that we're very happy to showcase with a very soon go live date. Here are some pictures of the inside of the unit. It's outfitted with a registration area, a front desk area, a lab area, and actually an exam room for the services that we intend to provide, and an outfitted bathroom. So the goal of the unit is to do education. We've started to build relationships with our local churches, with our local FQHCs, with our goal to promote cancer education, share decision-making, and let the men of the community know that it's important to discuss this topic with their providers. We're going to have a fully outfitted unit as well as fully staffed with PA, provider, and medical assistance and registration area for the unit. With, of course, as I've mentioned before, with collaborative measures, with the local folks to offer the cancer and early detection prevention information that patients would need to at least start the conversation. I'd like to also add that there will also be a health educator involved in our program. We're still in the midst of building that particular role and how it would function, but definitely provide education where our goal will be to definitely go out first, perhaps, schedule education sessions with our churches, with our community-based organizations. And then the goal after that would be to bring the unit in to provide the cancer screening services that we like to offer. At the end of the slide here, we have information where you can reach us. Our goal live data set for the first week of April for the unit. If you need to reach us to book any visits or appointments, here's our information, and we'll share this at the end of the presentation as well, for us to coordinate perhaps a visit at your local community. I'd like to then pass it down to Dr. Vinayak Wagaskar, who's with us. He's part of our urology team.
Right. So hello, everyone. I'm Dr. Wagaskar. I'm one of the urologists who work in Mount Sinai. Thank you for having us here. Yeah, I think Yohara explained it very well. So just the name, it's a prostate cancer screening. It's not really a screening. It's more kind of education, more kind of early detection, and more kind of like reaching out to the community who cannot come and like who cannot, who will not have like a knowledge of what exactly the prostate cancer means. Like, so the prostate cancer is essentially, it's the second most common malignancy in the United States. Everybody knows that. So the risk of men who are diagnosed in a prostate cancer, usually in a lifetime, it's 1:8 for non-Hispanic white men, but it falls to 1:6 in their lifetime to African-American men. And also there is an evidence that they are twice as likely to die from the cancer once they are diagnosed. There is like a demonstration, like there has been 2 recent epidemiological studies that have demonstrated that if like all of these men get an equal healthcare access, it's provided to like non-white, non-Hispanic white men and African American men, the outcomes will be the same of both. So this is something really important, and that's why like our team is reaching out to the people who really needs it. Also, there is an evidence that has emerged over past 2 years to explain the differences between prostate cancer occurrence and mortality between African American men and non-Hispanic white men. It points to multifactorial causes. So not only like it's a clinical test. It's also like there are some biological, some genetic differences. All those things causes higher incidence of and mortality of prostate cancer. And I would like to echo Dr. Daniel, who has presented about shared decision making. That's a fantastic talk. PSA is like non-specific test. It itself causes a prostate specific antigen. It's not a cancer specific antigen. So you can see like prostate is it's not a representative of the prostate cancer screening in general, but almost all randomized trial that has been conducted till now that has evaluated the PSA-based screening for prostate cancer has demonstrated a benefit in terms of lower stage and grades of the cancer. So we can diagnose the cancer at an earlier stage and at lower stage, which treatment will be possible at that point. And also there are several studies that has also revealed a significant reduction in prostate cancer specific mortality, and that are attributed to PSA-based screening for the prostate cancer. So these are the points I just want to mention. Again, like PSA and this van will provide like point of care PSA to the gentleman who needs it. It's not about the screening, but who needs it. And we will educate them, and the shared decision making, of course, will be done on the site. Let us know if you have any questions, please.
Thank you so much, Yahira, Errol, and Dr. Wagaskar for that information and all of your outreach efforts. We appreciate it. All right, moving right along, I would like to introduce our next speaker, Giuseppina Caravella, who is a community health education specialist at Stony Brook. And she is going to talk to us today about a focus group study to address racial disparities in prostate cancer.
Hi, everyone. My name is Giuseppina. I am from Stony Brook Cancer Center, which is out on Long Island, and I'm a health education specialist. And we have a current research study that we're just starting now called Addressing Racial Disparities in Prostate Cancer. So a number of people that came before me spoke about why that's important, but I'm going to go a little bit about our project. So I'm from the Office of Community Outreach and Engagement. And so our primary goal is to reduce the cancer burden and disparities in our local community. So our local community and catchment area consists of Nassau and Suffolk counties. And we plan to do this through surveillance, prevention, education, screening, engagement, and catalyzing research. So this is a little bit of the research piece. So the need, I'm just echoing what everyone before me said. There are definitely disparities when it comes to prostate cancer. Prostate cancer is common. So this number is slightly different than the person that came before me said. And I'll just say that my source was the National Cancer Institute, and it's from 2019. But 1 in 8 men would be diagnosed with prostate cancer in their lifetime, but that number is 1 in 7 for Black males. And Black males are 1.8 times more likely to be diagnosed with late stage prostate cancer, and they're over 2 times more likely to die from prostate cancer. So there's definitely a need for this community. So our project is we're facilitating focus group discussions with the goal of identifying barriers to care to help our staff design an effective educational intervention to increase knowledge around prostate cancer screenings for Black persons in our community. And so we're in the process right now of carrying out these focus groups. This is our flyer, and we've partnered with Dr. Dazan Phillips and Dr. Yuri Jadot, and they work at Stony Brook, and they're going to be facilitating these groups. So, we wanted to create an environment where the men would be comfortable in having these conversations. Obviously, I don't think they want to talk to me about their concerns about prostate cancer. So Dr. Jadot and Dr. Phillips have been partnering with us on this initiative. And right now we're just doing Nassau and Suffolk, but we are partnering with Mount Sinai, hopefully, and possibly doing some New York City groups in the future. So this is our information. Due to COVID, we're holding them virtually. We're doing them via Zoom, and our qualifications are listed on this flyer, and our contact information is also here if you have any interest or any questions, and we're going to send this to the group as well to share with you guys. And this is just our general contact information if anybody has any questions. Thank you.
Josephina. That's great information, and it sounds like a wonderful project. And as Josephina mentioned, we will be sending out a resource guide. I know there's a lot of information in the presentations today, so don't worry, we will be sending some follow-up information to all of the participants with the resources. Okay, and moving along, last but not least, I would like to introduce Dr. Kara Watts, who is a urologist at Einstein. She's going to be joining the Q&A panel today, and she's also going to be saying a few words about her program. So welcome, Dr. Watts.
Hi, good afternoon. Thanks so much for this opportunity. I'm Kara Watts. I'm at Albert Einstein Montefiore Medical Center in the Bronx. And we've been partnering with our Community for Population and Health outreach here to sort of revamp how our prostate cancer screening services are running. What we have actually found is that here across the Bronx, we actually, over the last 10 years or so, with some of the changes in prostate cancer screening guidelines, we have found a problem with our men being diagnosed at later stages of disease for prostate cancer compared to similar men in other parts of the country, sort of the national average. So we are working to improve some of our community outreach events, both with community leaders, maybe counterparts to someone like Mr. Brown in certain boroughs around the hospital, and also improving the communication between our department and the primary care doctors who are doing the screening to help make men aware and how to lead a proper conversation with them in terms of screening based on the shared decision-making model. Thank you.